Thank you very much for your nice introduction. So I will start this talk. This talk is talking about the etiology and treatment of benign and malignant gynecological cause of massive bleeding. As an introduction, I try to summarize what is the definition of massive bleeding. It could define as a major blood loss more than 500 milliliters occurring in 12 hours and responsible of hemodynamic shock. Benign cause of massive bleeding are dominated by obstetrical bleeding, postpartum hemorrhage, or cervical or vaginal tear after delivery, uterine vascular abnormality. In some cases, it could be uterine surgery complication, bleeding diastasis, and it's extremely rare that we have uterine fibroids or adenomyosis responsible of major bleeding. So I just skip this part because it's not major. For malignant cause, they are dominated by cervical cancer and endometrial cancer evolution. They just invade the surround tissue, potentially cervical biopsy, and bladder and rectal cancer invasion. So to get familiar with the anatomy and to just thinking about treatment, how can we figure with the treatment? We just have to know the vascular anatomy because it should, the vascular access will be our way to work. So usually there is two arterial input. In general case, the uterus, the cervix, arteries arise from the iliac intern arteries through the gluteal artery, the inferior gluteal artery, and gave uterine artery, vaginal arteries, and there is some very small cervico-vaginal arteries arising from the uterine artery, and the ovarian artery coming directly from the uterus. But in some cases, it's only 1% of the population. There is no uterine artery and everything coming from the ovarian artery. As it's shown on this, next. Okay, so image guidance should be very helpful. The angio scanner could be helpful to target the artery, but in that condition, it could be obviously reasonable to don't use the CT scanner. The CBCT, the C-arm combined CT could helpful to target the bleeding site, and especially for tricky navigation, it could facilitate the navigation, increase the targeting, and if you don't have the CBCT technology, as it's shown on those two videos, you just have to keep in mind that to reach the artery for the iliac intern artery, the catheterization, this is the ipsilateral oblique, and for the uterine artery, it is the contralateral oblique. Just thinking in your mind that women do everything in a reverse position than a man. Because for prostate, this is the same thing like a man. I'm sorry. Anyway, just example. So this is a regular anatomy from the iliac internal artery with the superior gluteal artery and the inferior gluteal artery giving the uterine artery, and this is the pudendal artery. And this is not visible here, but you have the superior vesicle, the inferior vesicle, and some rectal branch. And in case of the absence of uterine artery, this is a very big and tortuous ovarian artery giving the vascular network for the uterus. Here, the big femur. So keep in your mind that if you don't find uterine artery, you have to find another way to catheterize it. And at least in some specific conditions, especially with advanced cancer, and when the patient receives some surgery, some ligation, there is some collateral coming from the obturator artery, from the inferior epigastric artery, the deep iliac circumflex artery. Those two arteries are delimited the border between the iliac and the femoral. Those two arteries are here, and they could have connection with pelvis and the uterus, like this very small artery was feeding something it could look like a recurrence of a cervix cancer. So keep in your mind that the arteries could be numerous. So few rules for safety embolization procedure, especially when you receive patient with major bleeding. This is a multidisciplinary approach. It's very needed to collaborate very well. It is important to use protocols and to educate and to train yourself, to train the physician, the nurses, and the tech. The tech are usually in the cath labs, and they are not very frequently in contact with very big emergency, and in that condition, they have to be very well trained. And at least, and this is the basic recommendation, but communication is maybe the point, and teamwork coordination should be a way to work. So why is it necessary to have all this sentence in our mind? Because this is a sentence coming from the World Health Organization that to overcome the emotional part of the situation, some strong algorithms are needed. So it means that it's a lot of emotion, a lot of pressure in that situation, so you have to be very well trained and to work together to reach the goal. So the people work together, the gyneco, the EIC and the interventional radiologist. So we try to define in our institution as a golden hour. This is the same approach like for trauma injuries. So resuscitation of patients with massive blood transfusion is conceptually similar to resuscitation after a traumatic injury. The goal is to restore, to control the bleeding, to restore hemodynamic parameter, to treat disseminated intravascular coagulation, and to ensure adequate systemic oxygenation delivery. So it's based on massive transfusion, fresh plasma, platelets, correction of blood loss, massive red cell transfusion, and crystalloid solution have to be preferred to macromolecules. It's very important because macromolecules may induce some allergy and not very well tolerate. And in case of very, very big, the use of adrenaline, mechanical ventilation could be needed. From our side, so from the interventional radiologist side, we need some tools. Usually you use a 4-5 French sheath, access sheath, biofemoral access. We use different kind of catheter, usually 4 or 5. So this picture is, you just have to choose one catheter that you feel confident that this is your catheter. For example, I like the Cobra one. I think it is very easy to use. And you have to have on your shelf some microcatheter to selectively catheterized. For the catheterization, and then to move to the embolic material, so we have different kind of embolic material. We have some resorbable material like gel foam. That is a temporary material. It could be solved in 3 to 3 weeks, depending on how it was injected, how much was injected. We have some microsphere. Usually they are spherical or not spherical, but very important, they have to be calibrated, meaning that they are sold by range of size from 100 to 300, for example. So you have to have calibrate spheres because it is obvious to use something very big in a very small vessel. We have also coils, so it is stainless steel small coils with fibers just to increase the thrombosis. And we have also cyanoacrylate glue that we can use in emulsion with lipidol. Well, lipidol is the oldest contrast agent available. So how to perform the embolization? So we can think of different manner. There is a proximal approach. It is selective, not super selective. It is fast. It could be interesting to create an hemostasis by decreasing the blood pressure into the target organ. But there is less risk of damage, tissue damage, but there is a high risk of recurrence and a potential high risk of recurrence by repermeabilization, but also by new feeders. You can go distally, so super selective technique. It is time consuming. You need some kind of habits. But the focalized treatment, there is less non-target embolization complication, but there is a potential risk on necrosis if you're very, very selective. What is the embolization technique endpoint? When we use some material, the material need to be chosen along the target vessel size, the potential non-target embolization, and the definitive or temporary embolization. So in summary, we use sphere for tumor, for cervix cancer, local regional invasion, uterine fibroids, or adenomyosis. We use coil when we have a main trunk artery injuries, typically for surgical biopsy complication. And we can use gel foam because it's resorbable for postpartum hemorrhage. And when we use glue, it is especially for arteriovenous malformation. The endpoint, it is really common to all this technique. It is to obtain a complete stasis, meaning that there is a no flow downstream to the embolic agent. What kind of complication we can have during procedure? So the post-embolic syndrome is dominated by pain, fever, nausea, and leukocytosis. It occurs immediately after the procedure, and it could lasting for 10 days, depending on the amount of occlusion. And it occurs in 50% of the patient. Usually, angiographic procedure complication could be a puncture hematoma, dissection during the catheterism, contrast media allergy, nephrotoxic effect. Non-target embolization result usually in that area of bladder or rectal necrosis. Bladder or rectal necrosis are very well tolerated, manifest usually that's only bleeding in the urina. For rectal necrosis, it could be more tricky to manage. And ovarian failure is also described. And at least we have some other complications, mostly related to fibroid tissue. That is vaginal discharge, uterine necrosis or rupture. And sepsis and abscess are very infrequent. So more specifically about the postpartum hemorrhage, as it was previously defined, it is an unpredictable but serious complication. It is associated with a very high rate of maternal morbidity and mortality. A leading cause in the leading cause of mortality, maternal mortality in developing countries. So need a very strong organization. The majority are preventable in 80% of the case. Usually this is the delay between the diagnosis and the treatment is quite long. If underestimation of the blood loss, lack of easy-to-use protocol, lack of education and training, and poor communication and coordination between the team. That's the reason why we have to work together. It is defined as a major blood loss occurring 24 or 48 hours after delivery. Just to understand what is the postpartum hemorrhage, it is during the delivery there is a cascade of 3 successive events. So the first is the placenta abruption, then the placenta expulsion, and then the uterus retraction. And it is a long-lasting contraction and very intense. In some reason, this contraction doesn't appear, and that's the beginning of the postpartum hemorrhage. And in some cases, there is some products stay inside the cavity and could increase this phenomenon. So etiology has been very well described in that paper, and they are strongly associated to pathologic placenta insertion, reduced production of conception, uterine rupture, birth trauma, twins, and macrosomia. Those factors are very well known to be associated to postpartum hemorrhage. So to establish a rapid control of those patients, it is usually the gynaeco use some drugs, some like oxytocin and superstone. But there is some local treatment that could be given. The Bacry balloon is more and more used in a developing country. It should be very efficient. We have the embolization, that our topics, but it could go to uterine ligature or hysterectomy in some desperate situation. This is the algorithm that we have in our center. We developed this algorithm because we are in a center without maternity, so the women are referred to us for embolizations. They need to be very well set. So we call it the golden hours, that if in 30 minutes nothing appears, and despite all those treatments, the patient have to be referred to us for an immediate embolization. And based on our experience since nearly 10 years, we have 5 cases of uterine hysterectomy for untractable hemorrhage and no death. So this algorithm should be very strong for us, and this is the base on our treatment. Just an example of postpartum hemorrhage. So those women were referred with a very massive uterus, and we selectively catheterized the uterine artery downstream to the cervix artery with a microcatheter, with a 4 French glide catheter, and then we push into that catheter an emulsion of gel foam, a big piece of gel foam with contrast media, and we inject it with force into the uterus arterial network until we have a complete occlusion of the uterine artery, and the cervicovaginal is still patent. This is the correct endpoint. So in terms of technical success, it's a very high rate, as we can see. And the leading cause of death is usually related to disseminated intravascular coagulation or amniotic embolism in our case of failure. So those factors are very well known now to be associated to postpartum failure, embolization failure. The placenta abnormal abscission, the hemoglobin level, low profile of coagulation, massive red blood transfusion, and fresh plasma are also associated, but they are very well linked to the low profile. So the presence of disseminated intravascularization and the recruitment of menstruation are independently related to clinical failure. So let's go to the second part of my talk. It is uterine arteriovenous malformation. Two kinds are coexisting. That is congenital. That's a true AVM with multiple arterial feeders with a central nidus and multiple drainage valve. All originate from abnormal embryologic development of the vascular network. And there is multiple channels that may extend into the uterus and invade the surrounding tissue. It could be the round ligament, but it could also the bladder. For the acquired arteriovenous fistula, mostly are related to some surgery or other things, and they are looking like a single artery mimicking an AVM, but there is no nidus. This is the big difference, there's no nidus. And they frequently involve the intramural branch if the uterine artery is artery and the myometrial venous plexus. So the presentation mostly are menometralgia or, in some time, massive life-threatening hemorrhage. The bleeding occurs when the endometrial is very thin and abnormal, and the vessels are exposed to the cavity, and just a very smooth trauma maybe opens this vessel and the bleeding starts. Usually there is a past medical history of C-section, of uterus surgery, a therapeutic abortion, or whatever. We can diagnose it before the complication occur with the ultrasound. Usually they occur like those small hypoechoic area in the endomyometrium. And when you use the color Dopplex, you saw it was this very big blooming and mosaic pattern. Just tell us that it's very high velocity. Angio-MRI could be helpful too. You can find the feeders. This is the arterial feeder, and this is the vein, the output system, the vein. Could be helpful just to make the diagnosis, and on the MRI, you just see a bulky uterus with different focal mass. So different kind of treatment are reported. Hysterectomy could be at least the treatment, but bilateral uterine artery ligation are done too, but there are a lot of recidive because of plenty of anastomosis. So transarterial embolization could be interesting because there is a low complication rate, fertility preservation because you keep your uterus in place, and you reduce the surgical risk, and the efficacy is reported between 17%, a lot of recurrence at the first month because of different feeders. It looks like that in angio, so by selective catheterization on the right side and on the left side, we see a very complex network with early venous drainage and stasis of the contrast. The stasis on the contrast is very important to the venous. So the treatment of that lesion, it could be very well performed with a microcatheter placed close to finally the communication between the artery and the vein, and use some lipidol and cyanoacrylate. Usually we use one volume form cyanoacrylate with 1 volume on lipidol, and we inject it until we obtain a stasis of the system into the venous system. And you can see it looks like the post-embolization appearance with the staining of lipid inside. The beads are not recommended because they are very small and you have a lot of risk of non-target embolism and paradoxal embolism. And if you put the coil, it looks like a ligation. It should be too proximal, so you maybe not treat enough the patient. Regarding malignancy, so most of gynaecological malignancy are managed surgically. So patients are referred to us when hemorrhage occurs for very advanced stage. Usually embolization by the iliac artery branch, uterine, vaginal, or vesical, or internal pudendal is efficient. Coil are useful for arterial tear. I will show you an example. But sphere have to be used as a first line treatment. And we have just to balance it between the risk of extensive necrosis and non-controlled bleeding. For example, this woman referred to us for a major bleeding after surgery. She had an hysterectomy. And we see just here, the ligation was not, the uterine artery ligation was not complete. So we put just a few pieces of gel foam and a coil into this trunk, and the patient was saved. Another case of a patient referred after a cervix biopsy. She had a very huge bleeding, and the angio confirmed the bleeding set, but we put some coil and to control it. And the other set, by the other side, you can just see the hypervascular aspect of the tumor. And that's the last one. It was a local recurrence of cervical cancer. So there is a huge invasion of the bladder and the rectal wall. Those images appear like that with a blush tumor. So you have to get very selective of this artery. This was the collateral of the gluteal artery. It was at the end of the pudendal. This is a rectal branch. You have to avoid that rectal branch, but embolize this area. It was based on vaginal arteries and superior vesical artery. And we did it on both sides, and the bleeding was controlled. Thank you.